Today on Coronavirus Explained, we're looking at whether people with diabetes are more susceptible to developing complications from COVID-19, and if so, why? A huge amount of data is being collected about patients as we move through the pandemic. Much of it is yet to be published and peer-reviewed. But early research gathered during the outbreak in Wuhan suggested around 20% of the hospital admissions for COVID-19 were for people with diabetes. Another study from China reported around 7% of people who had diabetes and contracted COVID-19 died of the disease. That compared to just 2% of those in the general population who contracted the virus, suggesting people with diabetes could suffer more severe complications. And today we have new data published here in England that found that 1/3 of those who have died with coronavirus had type 2 diabetes. But researchers caution that connected risk factors like obesity might explain some of the link. Let's discuss that link with diabetes further. I'm joined by Paul Franks, Professor of Genetic Epidemiology at Lund University Diabetes Centre, who is in Helsingborg in Sweden, and Professor Carl le Roux, a metabolic medicine physician in the Diabetes Complication Research Centre at University College Dublin. Very good to see you both. Professor Franks, could I start with you? Why do you think people with diabetes might be more at risk of COVID-19?
Well, it's well known that that people with diabetes are more susceptible to infection, and certainly looking back on previous coronavirus epidemics, MERS and SARS, people with diabetes, particularly type 2, didn't do very well if they contracted those types of coronavirus. So it's a problem that's been recognized in the past. It's well known that people with diabetes are susceptible to infections and don't fare well with them. So, that's the background to this, and it probably isn't surprising that, in this case with COVID-19, many people with type 2 diabetes in particular have suffered greatly, and unfortunately the fatalities amongst that subgroup of the population have been especially high.
Professor le Roux, does it seem now as well that we initially thought COVID-19 was a respiratory illness, but that now in fact might be circulatory, and could that help explain this link to diabetes?
That's right, and our intensive care specialists are telling us that when they try to treat patients with COVID-19, it behaves in a different way than other people with acute respiratory distress syndrome. It appears that it is the blood flow around the lungs that are impaired. Now, of course, if the disease do this, and you already are treating patients with diabetes, be that type 1 diabetes or type 2 diabetes, which also impairs the blood flow around the lungs, it makes sense why people with diabetes are at much higher risk.
So, Professor le Roux, is type 1 or type 2 more susceptible? Do we know?
It's actually the data that you referred to, published from the UK today, that shows that both patients with type 1 and type 2 are at risk. It appears that people with type 1 diabetes at 3 times the increased risk, while people with type 2 diabetes at least twice the increased risk. So therefore both are at risk, and therefore our advice to these patients need to reflect the new information.
Professor Franks, does the evidence also show that people with diabetes who then get COVID-19 tend to also have more severe symptoms, and do we know why that would be?
Well, I mean, certainly the data, as you pointed out in the introduction, is still working its way through the peer review journals. So I think most of what we can be fairly confident about at this stage is still coming out of China in terms of the published literature. Whether or not patients are presenting with more severe symptoms of COVID-19 isn't entirely clear, but you certainly would anticipate that because people with diabetes are more susceptible to the adverse consequences of COVID-19, that they would be more likely to present with symptoms and not be asymptomatic, as we know a very large proportion of the general population is.
And Professor le Roux, what are your thoughts on that, about why they might be more susceptible? Is it to do with what you're explaining with the blood vessels around the lungs?
I think that's part of the explanation, but also we must remember that people with diabetes, as Paul outlined, are at higher risk of any infection because their immune systems are impaired. But you also have these other complications that come together with diabetes, for example, obesity, previous cardiovascular disease, but also age. And we can see that the patients that have all of these factors together, the older people who have diabetes and also have heart disease or hypertension, are even further increased risk. So it's about understanding this in totality and not one factor on its own that explains the entire phenomenon.
So Professor le Roux, how has that been for people with diabetes living under lockdown conditions with all of this data coming in, knowing they are potentially more susceptible? It must be a very frightening time for some people.
It's very frightening. And when we talk to our patients, they tell us that the public messages that's come out has not been coherent. We haven't been good enough at communicating with our patients, and therefore many people have been frightened. Other people have actually found that being in an environment where they can control everything, where they can control their diet or control what food they eat, has actually been a positive. So it's not universal that everybody is suffering or everybody finds it very hard. There are some examples where it's worked in people's favor. In totality, however, we need to improve the information, and that's why the research is so critical that's coming out. And I really want to commend our colleagues that are doing this very difficult research on the hoof and trying to get the information out to the public as quickly as possible.
Professor Franks, hearing that about the importance of information, I know you've been involved in the app that is used for COVID symptoms. Tell us about your involvement in that.
Yeah, so we launched something called the COVID symptoms study in the UK initially at the end of March, then in the middle of April in the US, and at the end of April in Sweden. And so far we've enrolled, I think, about 3.6 million participants across those 3 countries. And those data have provided an incredible insight into the symptoms and risk factors of COVID-19. One that has been well publicized has been something called anosmia, which is the loss of your sense of smell and taste, which it really does help define COVID-19 from other diseases when you mix that with sore throat and fever and these kind of things. So there's been a great deal of data that's come out of this very large international study, the COVID symptoms study. Now, I think there's a sort of immediate public health benefit from those data, which is that we've been able to put together dynamic maps that show where COVID-19 is likely to be emerging within these different countries, which does give the hospitals about a 5 to 7 day advance warning of an increase in admissions, at least in the UK that's been shown. So a nice, powerful early warning of COVID-19 hotspots within the countries. But of course, all the other data that we have, the 50 or 60 million data entries that our participants have now made, have led to some really interesting findings around the patterns, for example, of the different symptoms, which ones tend to go together, and if they go together, do they relate with adverse outcomes? So that would be one example of a piece of research that's just being submitted for publication tomorrow, in fact, from the study.
Professor le Roux, a very important question, if you are a patient with diabetes, would have to be around medication. Are there any links around the medication that patients are taking and COVID-19? Any advice that you have there?
There's been a very controversial issue because, of course, the first rule in medicine is always do no harm. And initially, there was a move that patients' medications were reduced because we were concerned that some of these medications may make people more susceptible. I think as more evidence is emerging, it is becoming clearer that we need to treat people with diabetes with the best medications we have and to the best of our and their ability. So the move is now that we need to try to get better control, not because we have the evidence yet to show that that makes a difference for COVID-19, but we certainly have the evidence that it reduces heart attacks, it reduces strokes, and reduces other complications of diabetes. And what we are also concerned about is while we are focusing on COVID-19, we should not forget that diabetes in its own right is a killer, that also makes people's quality of lives much less. So we need to treat this as a chronic disease and continue to treat it the best we can.
That is an incredibly important reminder for us to end on. Professor le Roux, Professor Franks, thank you both very much for being with us here on BBC News. Thank you for joining us. See you again soon. Bye-bye.